Bismillahirrahmanirrahim. Good afternoon, everybody. Today we are going to present an interesting topic. It is a recently published topic in the Intensive Care Medicine Journal, which was published May 2022. And the title of our topic is 10 tips to optimize vasopressors in critically ill patients with hypotension. And since we are using the vasopressors on daily basis, so we have to know at least the few tips that can help us to adjust the vasopressors use in our patients. The first goal that we have to set goals for mean or diastolic blood pressure. So better than targeting a systolic blood pressure in a patient who is hypotensive or critically sick, whatever the cause of shock, better you have to set your goals for a diastolic blood pressure or the mean blood pressure, because the diastolic blood pressure is the key for coronary perfusion pressure. And we know as the myocardium contracts, the coronary perfusion will be minimum. The flow to the myocardium will be minimum during systole. But during diastole, when the myocardium starts to relax, then the coronary perfusion will get better. And because we have this equation for organ perfusion pressure, it is influenced by the MAP rather than the systolic. And the equation said that the organ perfusion pressure equal MAP minus central venous pressure. For the coronary perfusion pressure, it is the difference between the aortic diastolic pressure and the left end diastolic pressure. That's why we have to correlate our goal for the patient to maintain the perfusion of the myocardium as well as the perfusion of the other end organs with the diastolic blood pressure and the mean arterial blood pressure rather than systolic blood pressure. And this is a simple example. Here, if you have a patient who is having, for example, cardiac arrest, and you start chest compression, and you have the diastolic pressure is low, then the perfusion to the myocardium will be low, so minimum coronary blood flow. So the results of this CPR will be less adequate. But while if you do chest compression with given epinephrine, then here your effect will be you will increase the diastolic pressure in the aorta. So then the coronary perfusion or the coronary blood flow will increase. So here you are likely to save the patient when you start the CPR together with epinephrine rather without epinephrine. Because here you increase the diastolic blood pressure for the patient, but here the diastolic blood pressure is low. So the flow to the myocardium is compromised. The second tip for the use of vasopressor that you have to individualize the arterial pressure target goals. And for us as pediatrician, we know that the blood pressure varies with the age, with the height of the patient. So we cannot use like standardized blood pressure for everybody. So you have to individualize case by case. And if you target a higher blood pressure, this will increase the risk for adverse events. So try to target reasonable blood pressure, and it will be variable from one patient to one patient because we have interpatient variability regarding the organ perfusion pressure. And if the patient had history of chronic hypertension, this is not an indication that you will target a higher MAP for the patient. So you have, even if you target a systolic blood pressure, you have to individualize the reading according to your patient circumstances. The third tip is that vasopressor induce an endogenous fluid recruitment and may limit positive fluid balance. How vasopressor will induce the fluid recruitment? Vasopressors will increase the blood pressure because they increase the systemic vascular resistance, and they can lead to some vasoconstriction in the venous system as well. And this vasoconstriction in the venous system will increase the systemic venous pressure, and then the venous return, because the flow from the venous system to the heart will follow the gradient. So if you have a higher pressure at the venous end, then the end result that you will have more blood flow coming back to the heart. So you increase the venous return, subsequently you will increase the cardiac output. So it have effect that mimic giving a patient a fluid bolus. So administration of vasopressor can therefore simulate a fluid bolus through endogenous fluid recruitment. And furthermore, the study showed that NOR-EP can decrease the inflammation induced capillary permeability, because we know that with the inflammation, you have capillary permeability, then the fluid will leak out from the intravascular system to the interstitium. And using nor-epi as one of your vasopressor will minimize this capillary leak. While we recommend ruling out hypovolemia with a fluid channeling, we start vasopressor administration early in patients with severe hypotension. So you don't delay the use of vasopressor, you can give it together with the fluid. If your patient is having hypovolemia, of course, priority for giving a fluid channeling and see whether your patient is responding to this fluid or not, and prepare your vasopressor to start it early before the patient will go to severe hypotension. And this diagram shows us the positive and the negative effect of vasopressors in the cardiac output and in the organs. So at the level of the cardiac output, as we mentioned, as we explained earlier, the vasopressor can increase the venous return for the patient, and it can mimic a fluid bolus even. And then with having a positive inotropic effect, then it will increase the contractility of the myocardium. And it can increase the coronary perfusion by increasing diastolic pressure. But on the other hand, the vasopressor do have negative effect on the heart, because once you increase the systemic vascular resistance, then the afterload or the forces against which the heart should work will increase. So this can lead to increased oxygen consumption for the heart, and it might fail the myocardium if excessive vasoconstrictions. And then also, because it is non-selective vasoconstriction, it can lead to increased pulmonary vascular resistance. So this, we have to put it in our mind if your patient is having pulmonary hypertension as well, because if you increase the systemic vascular resistance, including the pulmonary vascular resistance, then the pulmonary hypertension will worsen, and then the cardiac output will be less also. And then ultimately, it can lead to coronary vasoconstriction and minimize the perfusion to the heart. These are the side effects at the level of the heart. And then at the level of the other organs, we know that it increases the perfusion pressure for the patients, and it can increase the blood flow. And for example, nor-epi can decrease the capillary permeability. But again, if you use higher doses of vasopressors and you induce excessive vasoconstriction, then you can reach the critical closure pressure, so the perfusion to the organs will be less, will be compromised. And then also the regional blood flow will be compromised, and the patient will have hypovolemia as well. So you have to balance the use of your inotropic support. And this is the indications in general for the use of vasopressors if you have low systemic vascular resistance, organ and tissue edema, capillary leak, arterial stenosis, cardiac dysfunction, and severe hypovolemia. And of course, you don't forget to give the fluid bolus together with the inotropes, so fill the tank and then compress. Our first tip that you have to reassess the fluid status and the cardiac output after initiation of vasopressor. So you started your patient already on fluid bolus, and then after that, you started your vasopressor. You have to reassess your patient. What is the fluid status of my patient, whether he will benefit from further fluid boluses or not, and how I will titrate the vasopressor. Should I go for a higher doses or no? This dose is enough, or should I go down? So as we know, all higher doses can cause excessive vasoconstriction, resulting in coronary mesenteric and digital ischemia, and can alter the cardiac output due to poor myocardial perfusions and increase in the afterload. We recommend that you reassess the cardiac function and cardiac output in hypotensive patients with vasopressor. But how can I assess my patient? So we can assess static variables, such as you assess your patient, check the blood pressure, you check the heart rate, the urine output, the central venous pressure. But all these variables does not predict the response to fluid well, and a dynamic test is usually preferred because all what I mentioned is static. So static will give me just a stat picture about the patient. We have to go for a dynamic predictor. So you can follow this diagram. You ask your patient, yourself this question: can my patient benefit from a further fluid bolus or no? You look at your patient. Your patient is fully controlled. That state, your patient is mechanically ventilated, deeply sedated, or paralyzed. He's not having spontaneous breathing. So you can do passive leg raising, internal fluid challenge. This will increase the venous return, and you will see after increasing the venous return with this maneuver, you look at the pulse pressure variation and stroke volume variation. And these two tools were validated as a good predictor of fluid responsiveness in pediatrics as well as adult population. And if your patient is spontaneously breathing, then these predictors might not be very accurate. So you go for a fluid challenge, your patient, you can give 10 ml per kg, and then evaluate the clinical response, and then check the cardiac output change. However, checking the cardiac index also is not a very good tool, but the stroke volume is the one which can tell you whether your patient is going to benefit from the fluid bolus or not. The fifth step is that you consider agent with different mechanism of action as a second line agent. For example, I started my patient with epinephrine, and then I did not reach my targeted goals for the therapy. So what I'm going to do, I'm going to add another inotrope or a vasopressor, but with a different mechanism of action. Norepinephrine is recommended as a first line vasopressor for patients with sepsis or distributive shock. Adding a second vasopressor agent with a different vasoconstrictive mechanism of action might limit the side effect of catecholamines. Low doses, just a minute, the laundry man is here. I'm giving a lecture, just take it, please. So we said that we have to add another inotrope with a different mechanism of action. A low doses of vasopressin decrease the risk of atrial fibrillation and may improve renal function in patients with a vasodilatory shock. Because we know that some of our inotropes can lead to arrhythmia. They are arrhythmogenic, such as the dopamine, the epinephrine, all of them, they are arrhythmogenic. But vasopressin has less risk for arrhythmia. Using angiotensin II in patients with hyperrenemia, reflecting an angiotensin II deficiency is associated with a better outcome. Some patients with shock, they have angiotensin II deficiency due to a reduced ACE activity or an increased dipeptidyl peptidase 3, which inactivates the angiotensin II. Septic AKI is associated with decreased angiotensin II levels or expression of angiotensin I receptors, and the use of angiotensin II in this patient was associated with a better outcome. So we know that if you have deficiency in angiotensin II, this is going to affect your vascular tone for the patients. So if in this category, they found that in this category of patients, you better give them angiotensin II. And this diagram, I will just simplify because we know that AKI in septic shock had different theories, and the theories are not well proven yet. And so the most popular theory says that because of the inflammatory process, the cytokine release, the endothelial injury, this is gonna lead to AKI in patients with shock. But this one, I found it in PubMed, and it explained that here you have this is the blood flow in the afferent arteriole, and this is in the efferent arteriole, and this is our glomerulus. So the GFR is dependent on the flow that comes to the glomerular. So here, if you have constriction here, what is gonna happen? That the blood will be shunted. So you have a glomerular shunt. So this glomerular shunting will reduce the amount of the blood coming here, and then this will reduce the glomerular filtration rate, and then your patient will start to have low urine output, and then he will manifest all the features of AKI, having increased phosphate level, having increased creatinine, having increased urea, and then he might need also, the patient might need dialysis because of all this alteration that happened during septic shock. Then the sixth tip, consider adding hydrocortisone in patient on high doses of vasopressor. So as we know that in the algorithm of septic shock guidelines, it says that if you use 2 inotropes and still your patient, you did not reach the goals for your therapy, so you have to add hydrocortisone. And this is why the theory behind that, I think everybody knows that, because they postulated that they have adrenal insufficiency. Adding hydrocortisone will help you reach your therapeutic goals and will help you minimize the doses of inotropes. But nevertheless, the impact on the outcome is unclear. It helps us when the inotropes reach our goals, but whether it can affect the outcome, this is not clear. Due to the wide variability of patients, the comorbidity the patient has, so you cannot judge whether it will affect the outcome of the patient or not. Then the seventh step, vasopressin in patient with right ventricular failure. And I think most of us know that in the last years, a lot of researches have been done to try to detect whether patients have a septic shock, they have right ventricular failure or not. And they define the right ventricular failure as right ventricle dilatation together with evidence of venous congestion. So if you do the echo for your patient, you find that the right ventricle is dilated. And if you measure the CVB is high. This can tell you that there is evidence of right ventricular failure. And due to the lack of V1 receptors in the pulmonary arteries, vasopressin does not increase the pulmonary vascular resistance. So it is one of the medications that you consider if you have right ventricular failure. Because if you have right ventricular failure and you go and increase the pulmonary vascular resistance, then the right ventricle will fail more because you increase the afterload for the right ventricle. So you try to use a substance that at least either will vasodilate the pulmonary vasculature, such as the milrinone, or an agent that can help me with low systemic vascular resistance, but will not touch the pulmonary vascular resistance, such as vasopressin. Among patients with systemic vasodilatation and altered right ventricle function, norepinephrine represent the first line agent, but vasopressin with inotrope is another alternative. And here, just like I wanted to the people to remember how the vasopressin will act. It has two actions. It leads to vasoconstriction, which will increase our systemic vascular resistance, and it will affect the kidneys. We know that it can lead to fluid reabsorption and increase the blood volume because it acts as antidiuretic. So it will help us to reabsorb more fluid and increase the blood volume, and this increase in the blood volume in the presence of a good contractility, it will end up with a good cardiac output. So the end result that you will have a better blood pressure for your patient together with the vasoconstriction. But don't forget, you avoid excessive vasoconstriction. And this diagram just to show you how the RV, the failing RV, will look in the echo. So the RV will be dilated together with the flattening of the septum. This septum should be towards inside the RV if the RV is normal. You will have it flattening, and then the left ventricle will be a D-shaped. And just to make it more clear for you, this is the echo. This is the left atrium, the right atrium, the right ventricle, and the left ventricle. You see here the left ventricle already D-shaped. The RV is dilated and the septum is flattened. This is what the diagram shows. It shows that this RV is failing. And so if the right ventricle is failing, it means that the cardiac output from the right ventricle is compromised. So if you have less blood from the right ventricle going to the pulmonary vessels and going to the lung, then the left atrium venous return is going to be compromised. So the volume received to the left ventricle will be also less. So your cardiac output will be less. So a fail in RV will fail the LV. A fail in right ventricle will fail the left ventricle, because we know that there is interdependability between the both ventricles. Then the S tip, there is no maximum dose of vasopressors. Although many institutes set targeted inotropic level, they said beyond that, unlikely that the patient is benefit, so don't go beyond that level. But surprisingly, the researchers show something different. High doses of vasopressor have been associated with higher risk of death, given the higher severity of illness of these patients. Of course, if you are needing higher doses, it means that your patient is more sick. Oshit et al. Reported 90 days survival of 40% in patients receiving vasopressor more than 1 mic per kg per minute. Underline fair survival on very high doses of vasopressor. Then the ninth tips, that enteral tube feeding can be initiated while under vasopressor, because many people think that if the patient on inotropic support, they postulate that there would be bowel ischemia. So you try to avoid initiation of feeding. But if the patient passed the first 24, 48 hours, you can start the feeding, because enteral feeding we know better than parenteral feeding. So norepinephrine and low dose vasopressin have been shown to improve mesenteric perfusion and gut microcirculation. On the other hand, impaired gut microperfusion was reported with epinephrine. Enteral nutrition is safe among patients receiving less than 0.3 mic per kg per minute of norepi. So if your patient is not exceeding this dose, you can safely initiate the enteral feeding. But if already you are more than this dose, you better wait till you come down with inotropes, and then you can initiate safely the enteral feeding. The last tip, the 10th tip, vasopressor can be safely administered through a peripheral catheter. Observational studies and randomized trials show it is safe to administer vasopressor, such as norepi, through a well-functioning peripheral catheter, because you cannot delay your patient. You did the fluid resuscitation, you started the inotropic support for your patient. If you waited for inserting a CVC central line for your patient, this might take time, and this time is very crucial for the patient. So you better start your inotropes, and then you don't delay the initiation of your inotropes because your patient doesn't have a central line. You can still give the patient doses of inotropes through the peripheral line. And this ends our talk. Thank you for your time. And I hope it was a helpful tips, 10 tips for the use of vasopressors. And thank you.